Good evening, one and all. We welcome you all to the 5th day of 1 week international seminar on women, child development, maternal health, breastfeeding, awareness, education, environment, health, well-being, sustainable development 2023, commemorating Azadi Ka Amrit Mahotsav, nation celebrating 75 years of independence, India's G20 presidency, United Nations Sustainable Development Goals 2015 to 2030 as part of awareness and campaigns, and also commemorating World Breastfeeding Week with the theme Let's Make Breastfeeding and Work in collaboration with Sri Holistic Health Foundation India, Sri Research Institute Center for Arts, Sciences and Wellbeing, and Multi-disciplinary fraternity. Before we start our sessions, let's take the blessings of Almighty.
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah.
The blessings of Almighty, we shall continue with today's sessions. Since last 5 days, we were discussing about the importance of breastfeeding and how breastfeeding contributes to the health, well-being, and sustainable development of the mother, child, family, community, nation, and the planet at large. We also have seen how the breastfeeding impacts and contributes to the reduction of greenhouse gases and also contributes to the reduction and impact of climate change effect, and also empower women and also children. We also have seen how this breastfeeding is contributing to the employment and also to the education and towards the diet and nutrition and health and well-being of the child, especially in early childhood years, which is very crucial for the next 50 to 60 years and so forth, as long as the baby lives as a grown adult. Now, there are various aspects of breastfeeding, what are the challenges involved in breastfeeding. Like we have seen how certain infant formula milk or milk substitute organizations are acting as a deterrent for breastfeeding by promoting their products in such a way that they are discouraging breastfeeding. There is nothing wrong to promote any product, but it should not be any deterrent to the natural or the order of the livings of human beings or larger species on the planet. As we have seen so much of benefits from breastfeeding, and discouraging breastfeeding is inviting lifelong diseases, illness, and poor performance in all aspects, physically, psychologically, emotionally, socially, cognitively, so that the infant is deprived, a citizen is deprived of reaching his or her fullest potential. So this is violation of human rights, because every citizen on the planet has equal opportunities to be not deprived of any opportunities. So right, if we see, every person has the right to have pure water, to have pure food, to have good, adequate diet and nutrition, to have healthy environment in which he or she can live and thrive and develop and prosperous and contribute to themselves, to their families, communities, societies, nation, and planet at large. So all these aspects, different aspects that are promoting, are very crucial for achieving sustainable development. So we'll see, we also have seen the components of human milk and how various components of human milk are contributing to the health and well-being of the infant, growth and development, and also in improving the immunity. We have seen that breast milk contains even stem cells that help them to repair any damages that is caused due to interaction of environment factors, both internal and external, and also help foster the growth of the infant in an appropriate way. And as infants and especially old people are prone to more accidents, this will also help the young toddlers, the infants, because falls are quite common when babies are trying to stand, sit, hold something. They always try to explore their environment, and it is not always possible to safeguard the baby due to various factors, like not everyone might be having enough space where the baby can be safely held, and exposed to the environment or surroundings. So in that case also, this breast milk helps to safeguard, protect the infant and child. And we have also seen the various challenges of breastfeeding and how those can be addressed. And we also have seen management of breastfeeding, including the anatomy and physiology of the breast and how and what kind of challenges we have with the breastfeeding. And we have also seen how there are various myths, taboos associated with breastfeeding, and dispel few of them. And we will also, in coming days, we have another 2 days, tomorrow and day after tomorrow, where we'll be looking at different aspects of breastfeeding. So today we'll look at the reflexes and the positions. So when we see the physiology of milk secretion from the breast, which involves many hormones in pregnancy, like estrogen, progesterone, prolactin, which are the 3 major hormones of this reproductive phase. The elevated levels of estrogen and progesterone during pregnancy prevent prolactin from stimulating milk secretion. With the removal of placenta, estrogen and progesterone levels fall dramatically, while the prolactin level remains elevated. This is the signal to the breast to begin milk production. Prolactin receptors in the breast have an increased affinity for prolactin immediately after birth. Immediately postpartum, colostrum, which has been present in the breast since about 20th week of pregnancy, which is known as lactogenesis stage 1, is available to the newborn for the first few days of their life until the milk comes in greater quantity. Normal term infants are born with a number of reflexes and behaviors to help ensure the newborn survives the transition from intra to extrauterine life. These reflexes enable baby to begin feeding immediately after the birth. The total amount of colostrum milk available the first day is small, which is around 40 to 50 ml, and it again varies from mother to mother on various factors, and it is well matched to the newborn's small stomach capacity of around 20 ml, about 4 teaspoons or 5 milliliter per kg. The full-term newborn stomach's capacity is somewhere around 20 ml, which is equal to 4 teaspoons of 5 milliliter. So milk will begin to appear for a few days postpartum, lactogenesis stage 2, where the woman breastfeeds or not, but the stimulus of the infant suckling at the breast builds and maintains milk production. That's why breastfeeding is important, because it stimulates and improves breast milk production. Otherwise, the baby will not get sufficient milk in coming days and for the full period. So it is very important for the mother to continue to breastfeed regularly, frequently. breast milk production is baby driven. That is, the normal full-term baby indicates when he is hungry and when he has had enough. Breast milk is easily digested, so the infant signals his need to eat or drink about every 2 or 3 hours, sometimes even more often, like 1.5 hours, anywhere in between 1.5 hours or 1 hour to 3 hours, or at least 8 times every 24 hours. In the early weeks, some babies, normal babies, cluster their feedings into one particular part of the 24 hours and feed less frequently during the remaining 24 hours. That is also fine. No need to worry. Because babies sleep longer, more than 12 to 16, or sometimes 17, 18 hours also, depending on the environment and the condition. So they might, and especially daytime, nighttime also, they adapt to the environment. And generally some children, they drink, they vouch for breastfeeding, irrespective of day or night, anywhere in between 1 to 3 hours. So the mothers may feel stressed because she has to keep awake herself so that she can take care of the baby and breastfeed. So mothers might be deprived of sleep unless and until mother can quickly go back to sleep. Certain women have issues, or for that matter, not just women, for that matter, it can be anyone, including men and women. Some people have difficulty in going back to sleep if they are disturbed or if they are waken up. So in that case, they might find some issues temporarily, but the benefits of breastfeeding, the joy and happiness of the breastfeeding is more than. And sometimes the baby also quickly adapts according to the mother, and they feed themselves mostly in the early mornings and daytime and in the late evenings, late nights. So that baby also sleeps for a good amount of time without disturbing mother. And whenever the daytime, generally certain babies are very active in daytime, certain babies are very active in the nighttime. And those babies who are very active, proactive in the nighttime are a little bit troublesome for the mothers. This also happens because baby sleeps whole day. Most of the time in daytime, including early day and late nights, early mornings, daytime, and late nights. So that causes the baby to be awake in the nights, most of the time. So if we can engage baby and also not deprive the baby, because enough sleep is also important, because they are at the fastest growth and development phase. So they need good amount of sleep, at the same time good amount of feed, because that is a crucial phase for rapid growth and development. So what we can do, we can provide, if we can engage actively with the baby in the daytime, and as the baby adapts to the schedule or to the mother accordingly, certain babies adapt to the schedule, and accordingly, they also be more active in the daytime and go for sleep for a longer duration, or at least for most of the time in the night time. That gives both the mother and child to have good sleep. So it all depends on the mother basically and the child, how they are communicating with each other and how they are adapting to each other. Along with that, the family and the environment. So it's all like, parenting starts from the day one. How mother and child establishes bond and try to communicate with each other. In a similar way, so that the communication and the bond is established, and accordingly they cooperate and collaborate with each other. So breastfeeding involves a set of reflexes and hormones that also drive the milk supply. Milk production is influenced positively by early, frequent, and effective milk removal, and negatively by late, infrequent feeds or feeding the baby other liquids or foods before 6 months of age. Because baby may not have sustained interest in breastfeeding, because baby is exposed to different types of foods, like different types of milk. So if baby is more interested in that taste or aroma or color, baby will naturally, because we are very selective, sometimes at least. So what we prefer only which we like more. So the baby, if there is a possibility, because we cannot even explain at that time to the baby, and it is very hard to communicate so that the baby understands. So that's why that is also one of the reasons to avoid all, even we have grown up so much, we have high IQ levels, still we are preying ourselves on junk food. What happens? More and more junk food, more and more diseases, illness and all. And poor baby at that age, he or she doesn't know which is good one. So the best available alternative should be breast milk, so that is the only thing available, and that is the best thing available. So that's why that is also one of the reasons baby should not be given any other feed, because any other feed is detrimental to their health and well-being. So that's why it is very important to continue to breastfeed, to introduce breastfeeding as early as possible, so that the baby gets adequate, healthy nutritious food. So that's why, and otherwise, and there is no other source of food, even the baby also relies and sticks to that breastfeed. If we introduce other things, then baby will say, I want that only. Then the breastfeeding slowly drops, and again milk production will stop. Again, mother has to face a lot of problems, because there is, and at the same time, infant will not get adequate nutrition. Again, that will deter the growth and development of the child. So to prevent all this, so no other food should be introduced before 6 months. And only breast milk is the option. So baby also, whenever she or he feels hungry, the baby takes the breast milk. So that also improves the milk yield of the breast milk. and also timely removal and frequent removal of milk. That will restore the milk supply and that will improve the mechanism. In a similar way, each time the baby suckles at the breast, the baby stimulates the release of prolactin, that is milk producing hormone, from the anterior pituitary, and oxytocin, milk ejection hormone, from the posterior pituitary. So prolactin is released from the anterior pituitary and oxytocin from the posterior pituitary. So it is the oxytocin that stimulates the myoepithelial cells to contract around the alveoli, making the milk flow, sending the milk down through the milk ducts. The milk ejection reflex or let down reflex may be noticeable to the mother as a physical sensation, such as pins and needles or flush of heat. See, the pain which is experienced by the mother is due to reflex. It is not that kind of severe or unbearable pain. It is just like pushing the milk from the breast outside so that baby can easily suckle and drink the milk, so that baby doesn't get strained with this process of suckling. Otherwise, what would happen? If baby needs to put all the efforts, then baby's jaws, the lips and the portion will get strained and baby will not be able to take the feed properly, adequate amount, frequently. So that's why the nature has provided in such a mechanism so that both mother and the baby puts adequate efforts so that the milk is generated and flows freely so that baby can suck the milk from the breast. So because of that pressure the mother may face, such as pins and needles or flush of heat, like they can sense the flow of milk basically. And that can be perceived in different ways by different women. Because again, it all our visualization and imagination. If we imagine that we are giving the greatest or the best diet to our child, if you visualize that and if you feed the baby, you will have immense joy. You will never experience any kind of pain. So in a similar way, some women do not describe feeling anything because they've used to it and they, it's a natural thing to feed baby. So they don't experience any pain. They feel absolutely normal. But they may see that milk is dripping from the nipples. So when milk starts to flow from the baby, changes the way he moves his mouth. So going into the pattern of wide excursions of his jaw and downward motion of the posterior tongue, resulting in a lowering of the pressure in infant's oral cavity and the increase in milk flow. The flow of milk causes the baby to swallow in slower, rhythmic, audible manner that sounds like a quiet cough. Swallowing is a good indication that milk is being effectively removed by the baby from the breast. So the baby may stimulate several ejection reflexes during the feeding. Each time the milk is ejected, it contains a little more fat. The milk that is present in the breast at the beginning of the feed, that is 4 milk, or the colostrum milk, contains about 1.5 to 2% fat, while the milk present at the end of the feed contains about 5 to 6% fat. Allowing the baby to feed without time limits enables him to get more of higher fat in milk. So providing fat-soluble vitamins, calories to gain weight, and the ability to wait 2 to 3 hours from the start of one feeding to the start of the next. The frequency of the feeding regulates milk supply. The more often a baby removes the milk, the greater the milk supply. So conversely, a baby who sleeps many hours at a time in the early weeks or feeds less than an average of 8 times in 24 hours does not have the opportunity to stimulate the breast, causing the milk supply to drop. So this is referred to as law of demand and supply. So because each breast responds to the amount of milk demanded by infant, it is possible to exclusively breastfeed more than one baby at a time, or to use only one breast initially. If the milk is not removed from breast, becomes full and eventually engulfed. At that point, a local factor known as feedback inhibitor of lactation begins to decrease milk secretion. This exact mechanism of feedback inhibitor of lactation is still under study, but there is some evidence that fills is serotonin. And we have talked about skin-to-skin experience, contact, kangaroo mother care. When this is practiced, mothers experience fewer breastfeeding problems. Milk production is enhanced and infants are more contented. Unmedicated newborns exhibit crawling behavior that helps them reach their mother's breast, and some, through not all, will feed within the first hour. Studies also suggest that extending skin-to-skin contact beyond the immediate newborn period continues to support successful breastfeeding. Even babies born by cesarean section can be allowed to skin-to-skin contact experience on the chest area as soon as the mother is alert. Babies are placed skin-to-skin after delivery also have less difficulty with subsequent attachment. Continue skin-to-skin contact in hospital and after discharge improves milk out. Hospitals can also encourage skin-to-skin contact by supporting continuous rooming in. Prenatal and discharge counseling should be done, providing mother with adequate information, along with fathers and other adult family members, participating in holding the infant in skin-to-skin contact and allowing the mother time to sleep, bath, or take care of other needs. So a number of studies, reports have appeared in the breastfeeding literature describing new approaches to help a mother-infant achieve comfortable, effective breastfeeding. And they have been called as baby-led breastfeeding and biological positioning. The way a mother holds her baby to breastfeed may also be influenced by cultural or family traditions. Whatever position the mother and her baby choose should be comfortable for the mother and also safe for the infant, as well as effective effective for both. There are several approaches. Infant should be in light sleep or in a quite alert stage, but not crying or active. A crying baby will need calmed before encouraging the baby to begin breastfeeding. A sleepy baby may not respond with a rooting reflex and may not take the breast. Unwrapping and undressing a baby may help awaken a sleepy baby. A gentle massage of the infant's back or the soles of the feet may also help. Mother should sit or lie down comfortably with her back well supported and bring baby in close to her. She offers her breast to the baby in a way that promotes good attachment of the baby's mouth to the breast. She may support her breast with all 4 fingers below and thumb resting lightly atop on the breast. There is often called a C hold. The baby should approach the breast with his or her nose towards the nipple, so that he has to tip his head back and reach up to the nipple with his chin, with his or her chin going close into the breast and well under the areola. Her thumb and fingers should be away from the areola so that baby can grasp the nipple and areola area without interference. Often we see mothers offering the breast to the baby using a scissors hold with the nipple between the forefinger and middle finger. If the fingers block the areola, the baby cannot attach properly. With the mother seated in this position, the infant should be held on the same level as the mother's breast, turned so that baby abdomen faces the mother's abdomen, tummy to tummy, held close and well supported with pillows or cushions. For baby-led or biological positioning, mothers are encouraged to lie back rather be in more sitting position. The baby is placed on the mother's chest and allowed to use infant's reflexes and natural behaviors to find either breast and self-attach. There are also various other methods like cradle method, cross-chest method. The baby lies across mother's lap. Baby's head lies on her forearm or in her hand on the side from which she is feeding. His head should not be in crook of her arm because that takes him too far out to be the side, and he has to bend his head forward and cannot get his chin and tongue underneath the nipple. There is also one more method, modified cradle. The baby lies across the mother's lap, mother's opposite arm and neck. This position is very useful for newborns and very small babies, giving the mother better control of the baby's head and neck than the cradle hold. And there is one more position, side sitting, football. In the side sitting position, baby and mother sitting up. Baby sits facing mother with his legs under arm. And mother's hand supports baby back and neck. This position is comfortable after a cesarean delivery because the baby's weight is away from the incision. Sleepy babies may stay awake and feed better in more upright position. Side lying, the mother and baby lie side by side with mother's lower arm extended so that baby can freely reach the breast. The way the baby grasps the nipple or areola area and pulls it into his mouth, her mouth, for feeding is referred to as attachment or latching or latch. Attachment is considered to be the most important factor for preventing early problems that lead to premature weaning. Normal infants are born with a normal number of reflexes and behaviors. These reflexes include a rooting reflex that prompts him to open his mouth and turn towards the breast when hungry. A light touch to the middle of the infant's upper lip will help elicit this reflex. The mother should aim the nipple towards the roof of the baby's mouth. The infant opens the mouth wide and brings his tongue down and forward the lower gum to pull the nipple into his mouth. A crying baby will need to be calmed since the tongue is usually elevated during crying and the baby's tongue needs to be down in order to breastfeed. When popularly attached, the baby lips are flanked outward over the areola. With effective positioning, the infant's tongue presses the nipple areola against the hard palate and then lowers the posterior area of the tongue and soft palate, creating a vacuum. This lower intraoral pressure results in the milk flowing into the baby's mouth from the areola, stimulating swallowing and further suckling actions in a rhythmic pattern. Assisting a mother to learn how to help her baby attach or latch on effectively is very important to preventing problems and achieving breastfeeding success. Always observe breastfeeding before intervening. Mothers and babies may be doing fine and need only encouragement. So elicit the rooting reflex by touching the baby upper lip with the mother's nipple. Bring baby into the breast so that baby gets a large mouthful of nipple and areola area. Once the baby is attached correctly, the infant's lips are flanked out, the mouth is wide open, chin is against the breast. The mother has a large areola, more of the areola is visible above the upper lip than below the lower lip. This is known as asymmetrical latch. Good attachment is where, while lips widely flanked out, nose touching the breast. Poor attachment is where lower lip is curled in and nose not touching the breast. But at the same time, we have to ensure, be cautious that the entire nose is not covered with the breast. It should be near to the breast or close to the breast because baby needs to breathe. So there should be gap, enough gap so that baby can breathe. Poor attachment reflected by tight pursued lips, space between the chin and breast, space between the breast and nose. Infant's lower lip pulled in. Mother may feel pain. Nipple may be flattened after a feeding or nipple abrasions and or cracking. Ineffective suckling technique reflected by no sounds of swallowing, short, quick, flutter sucking movements only. Mother may also feel pain. So this is because of poor attachment and ineffective suckling. So if someone is assisting the mother with getting the baby attached, the helper's hand should support the head, neck, shoulders below the infant occiput. Forward pressure to back of the head causes the baby to arc, moving it difficult for the baby to attach effectively. There are significant differences between what is necessary for a baby to remove milk from a bottle with an artificial nipple, in contrast to effectively breastfeed. Breastfeeding requires the coordination of suckle, swallow, breathe, and tongue action. The artificial nipple feels and functions differently, and milk flows from a bottle by simple suction, compression, and gravity. Until the baby is an effective breastfeeder, the mother's milk supply is established. It is better to avoid artificial nipples, including pacifiers, so that oral stimulus is consistent. Once a newborn has mastered breastfeeding, usually by 3 or 4 weeks of age, Many babies will very likely to be able to transition between both methods without difficulty. If breastfeeding is temporarily not possible, or there is an acceptable medical reason to supplement, a baby can be fed by cup if necessary. This helps to avoid the problem of becoming adapted to the bottle feeding technique and refusing to return to the breastfeeding. So that's why a baby should not be introduced to any other food or any other method other than breastfeeding. Mothers breastfeed successfully without knowing all of these details, but these details may be helpful if the mother is experiencing problem or if baby is not gaining or feeding very frequently. A common explanation is ineffective suckling, which can often be easily modified. So signs of effective suckling include a few rapid sucks at the beginning of the feed with no active swallows of milk, stimulating the oxytocin reflex and milk flow, call-up suckling, and nutritive suckling, deeper, slower sucks, 1:1 suck per swallow, with a brief pause when the milk starts flowing. Audible swallowing, a quiet coo sound shows that the milk is being transferred. 3 or 4 good-sized bowel movements, 24 hours, and 25 to 30 grams weight gain per day after the milk comes in. Be sure to observe breastfeeding before suggesting interventions. Intervention should be suggested only if a problem exists. Breastfeeding is baby-led. The baby asks to feed when hungry and stops when it is satisfied. So feeding on demand allows the infant to indicate when he or she is hungry. Crying is a late sign of hunger. So breastfeeding should be initiated in response to early hunger cues rather than waiting until the baby is crying. So early cues include waking up, bringing hands to his or her mouth closer, rooting, mouthing movements. These are the cues that babies need breastfeeding. Breastfeeding should also reflect the needs of the mother, and she may try to get baby to feed if her breasts are becoming uncomfortably full. So feeding patterns may greatly vary among babies. Some feed quickly, others slowly. So the important thing is to feed long enough to obtain the hind milk. Milk has slightly more fat with each let-down ejection. Infants usually signal by spontaneously releasing the breast, falling asleep with the nipple in its mouth, or discontinuing suck-swallow patterns when they are either finished or ready to change sides. If necessary, burp baby to see if displacing air makes baby interested in taking more. Then offer the second side. Sometimes one breast is sufficient. Switching starting sides at each feeding. So mothers have variable amounts of milk fat and total milk volume throughout the day. So the baby may feed for different lengths of time from one feeding to the next. Every mother-infant pair is different. The baby's style of feeding and the flow of mother's milk vary from pair to pair. Very long or very short feeds may indicate problem and should be evaluated. The best way to evaluate the baby's effectiveness is to observe a feeding. Look at how the baby is attached, listen for swallows, assess whether the mother is comfortable throughout and baby is content after the feed. If a mother needs to release her baby from the breast during a feeding, she can break the suction created by feeding using a finger to press on her breast at the junction of baby's lips, or by putting a clean finger into the corner of the baby's mouth. This gentle manner of helping the baby off the breast can help prevent sore nipples. The nipple should appear as they did before the feeding, round and not reshaped or flattened. The healthy newborn should be given opportunity to breastfeed immediately after the birth, a time when normal, non-medicated term babies are most alert. Skin to skin has been shown to be very important to breastfeeding success. The initial alert period is usually followed by a period of sleep. Though many newborns initiate breastfeeding with first 60 minutes of birth, not every normal baby does this. Some simply nuzzle and some do not attach until a bit later. As noted earlier, studies suggest that opportunity for skin-to-skin contact is very important to breastfeeding success. A newborn usually signs the need to feed every 1 to 3 hours time from the start of one feeding to the start of the next. Newborns often feed most frequently during first 2 to 7 days. When the onset of more abundant milk supply, lactogenesis 2 begins. A daily frequency of 18 to 12 feeds is ideal, especially in the early weeks of life. Many normal babies seem to be breastfed more at night, especially during the first week or 10 days. So during the first 2 to 7 days, many healthcare providers believe that intervals of greater than 3 hours are not appropriate. The mother should gently awaken the infant and offer the breast if he sleeps longer than 3 hours. Or if the mother feels too full, if the baby does not want to feed, he should not be forced or given a supplement. One lactation is established, a pattern of at least 8 feedings per 24 days, day and night including, is common. Sleeping longer stretches at night may be patterns seen after 6 weeks of age. A baby who sleeps all the night in the beginning is probably not getting enough calories. Since prolactin levels are highest at night, night feeds are important to ensure adequate stimulation for milk production and suppression of ovulation. Some babies will cluster feed, that is, feed very frequently at times and extend the time between other feedings. If the baby is gaining well, this is a normal variation. A trained observer or a healthcare provider or a lactation specialist or a consultant should watch a feeding to evaluate the baby's position and attachment and the newborn's effectiveness of suckling. The main concern of most parents is whether the baby is getting enough milk or not. If the mother is taught to watch for the signs of adequate intake, she can feel more relaxed and confident. When the baby shows the following signs, conversely, if the infant does not show these signs, then he or she may need an evaluation. So frequent soft bowel movements, 3 to 4 or more, 24 hours by day 3, yellow stools by day 4 during the early weeks. After 5 to 6 weeks, some normal breastfed babies do not stool for several days. Wet diapers, 6 or more, 24 hours by day 3. Diaper count may not be accurate if newer absorbent diapers are used, but a normal infant will urinate at least 6 times in 24 hours. So sounds of swallowing during a feed, contended between the feeds, and average weight gain of 20 to 30 grams per day or 100 to 200 grams per week. Recent studies indicate that the velocity of the gait gain varies with birth weight, smaller babies gaining more slowly than larger babies. Full-term infants should start to gain weight by the 3rd to 5th day of life. Most infants regain birth weight by about 7 to 10 days after birth. Infants who lose 7 to 8% or more of their birth weight need careful evaluation and follow-up to be sure that there isn't any problem. Babies who breastfed early regain their birth weight earlier. Additional signs for the mother. Mother breasts feel full before a feed and softer afterward. Ejection, let down sensation in mother's breast. Not all mothers experience this sensation, but whoever is experiencing. Uterine cramping may be felt for the first few days with every breastfeeding. This is a sign of oxytocin release and let down. It is helpful to talk to the mothers about their knowledge of breastfeeding and about their individual situation. In order to know the best how to provide information and support, open-ended questions allows the mother to express her concerns and worries. So for those who are interested, especially mothers or anyone, a document titled Protecting, Promoting and Supporting Breastfeeding, the Special Role of Maternity Services, was issued as a joint statement by the World Health Organization and United Nations Child Fund, UNICEF, in 1989 to provide guidelines for hospitals and maternity centers. The document described 10 steps to successful breastfeeding. The evidence-based 10 steps now comprise the basis for the International Baby-Friendly Hospital Initiative, in short known as BFHI, a UNICEF WHO-sponsored hospital-centered voluntary program of training and policy development to support the breastfeeding mother and newborn. At the time of preparation of the third edition of the self-study material, nearly 20,000 hospitals around the world have been designated as baby-friendly after the initiative. So let's look at the 10 steps that provide the foundation by requiring a hospital policy that supports breastfeeding and trained staff who can assist the mother, and specific clinical practices that are delineated. Having a written breastfeeding policy that is routinely communicated to all healthcare staff. The Academy of Breastfeeding Medicine offers a model hospital policy, Protocol 7, which can be downloaded without charge and adapted as needed by hospitals and maternity services. Step 2, train all healthcare staffs in skills necessary to implement the policy. A course to provide basic training for healthcare staff has been designed by World Health Organization and is available for downloading without charge from the World Health Organization website. Step 3, inform all pregnant women about the benefits and management of breastfeeding. Women need to know early in pregnancy the importance of breastfeeding in order to make an informed choice about infant feeding. The mother's previous experience with breastfeeding should be elicited in order to correct misconceptions or to prevent problems she experienced before. All pregnant women should know what to expect in the first few days, postpartum, and the basics of continued breastfeeding. Step 4, the baby should be given skin-to-skin contact immediately after the birth so that he or she can find the way to the breast and start to breastfeed immediately after a normal delivery. The suckling reflexes are present at birth, and the colostrum in the mother's breast is full of immunoglobulin and vitamin A. Colostrum is considered by many to be the baby's first immunization, and this breastfeed should be skin to skin. A mother who had a cesarean birth should start to breastfeed within 1 hour of being able to respond to her newborn. Step 5 shows mother how to breastfeed and how to maintain lactation, even if they should be separated from their infants. The mother should be shown how to position and attach her baby, and a breastfeed should be observed and evaluated by the knowledgeable observer. Every mother should be shown how to hand express her milk. If she is separated from her baby, she can maintain her milk supply, and in many cases, the milk can be saved and given to the baby. Step 6, give newborn infants no food or drink other than breast milk unless medically indicated. Supplementation with breast milk substitute should be given only if medically indicated. If supplements are necessary, human milk is best either from the baby's own mother or donor milk. If substitutes for the human milk are introduced, there are risks of allergies. Soy-based formula is probably no better than cow's milk-based formula. If a non-human milk supplement is required, hydrolyzed cow's milk is the best to decrease the risk of allergy. Even in hot, dry climates, human milk contains sufficient water for a young infant needs. Additional water, sweet drinks, or teas are not required. If the baby is supplemented, there is a missed opportunity to practice breastfeeding skills, and baby ingests less breast milk. With less human milk intake, there is less immunological protective effect. Step 7, practice rooming in and allow mothers and infants to remain together 24 hours a day. Minimizes separation, provides practice for the mother in the skill of breastfeeding. Mother can respond to her baby's needs right away and start to build her milk supply. It is a prerequisite for a baby-driven feeding pattern. Step 8, encourage breastfeeding on demand. Frequent suckling is the stimulus to produce enough breast milk for the baby's needs. Frequent effective feeding stimulates passage of meconium and helps minimize physiologic jaundice. Step 9, give no artificial nipples or pacifiers to breastfeeding infants. Use of these devices introduces the possibility of reinforcing poor suckling technique and may be the source of infection. The breast both pacifies and nourishes the infant. Step 10, which is the last step, foster the establishment of breastfeeding support groups and refer mothers to them on discharge from hospital or clinic. Support groups provide information and socialization, help mother identify the supportive people in her environment, family, friends, and community support groups, encourage mothers to get help from family and friends during the early postpartum period. Rest and relaxation are helpful both to recover from birth and after for successful lactation and breastfeeding. An understanding of the anatomy and physiology involved in the natural process of breastfeeding is essential in order to provide care that supports optimal breastfeeding practices. The breastfeeding routines are based on the evidence-based physiologic principles, and adhering to them prevents problems from developing. Helping a mother and infant off to a good start is one of the best investments in time and effort. So there might be certain clarifications required. This is common. We have seen yesterday the different shapes of nipples, like inverted nipples, flat nipples, hairy nipples, and various other nipples. As long as the areola is soft and pliable, babies can effectively breastfeed on a variety of shapes of nipples. However, mothers and babies sometimes need a little extra help. The natural hormonal changes during pregnancy that affect the breast often cause the nipple to protrude to some degree. Some babies are able to pull out the inverted nipple and feed well. With every breastfeed, they bring the nipple out a little more. When only one side is involved, the mother may elect to continue breastfeeding primarily or exclusively from the unaffected side. Other newborns need the simulation of a longer nipple before they will begin suckling. In this case, mother can use a pump to gently draw the nipple out before each feeding. She may need help with the position and attachment from a knowledgeable person in early postpartum period. The helper should teach the mother to evaluate the feed by providing with her indicators of adequate breast milk intake and give her resources for additional assistance after discharge from the hospital. As a last resort, an ultra-thin silicone nipple shield can be temporarily used. It is the best to avoid bottles and pacifiers in case of inverted nipples, because the baby can get used to the feed and flow of longer artificial nipple and may refuse the breast. So women were also, with inverted nipples, were also told to use a variety of exercises and devices to avert their nipple. But most of the times, these strategies were ineffective. Women who did nothing to prepare their nipples prepartum had the best results. Current advice then is to alert the mother when she should request assistance in breastfeeding at the time of delivery, postpartum, until the baby is feeding well. So there might be certain conditions like sore nipples, nipple trauma. Among many myths about breastfeeding, the common is that breastfeeding hurts. Although painful nipples is a major reason given for early cessation of breastfeeding, today there are increasing number of healthcare providers and lactation consultants with skills and knowledge to assist mothers in avoiding nipple problems. Nipple tenderness and sensitivity will usually subside within a few days if the position and attachment are correct. Intense prolonged pain is usually related to physical trauma, which is mechanical, and due to infection. A mother with intense prolonged pain needs an evaluation and management by an experienced lactation expert. So this trauma to the nipples is caused by various factors like improper position and attachment, engorgement making it difficult for the baby to effectively latch, not breaking suction when removing baby from the breast, ankylosing, short lingual frenulum or tongue tie, mandibular asymmetry or torsicollis resulting from intrauterine positioning, delivery-related issues which may cause alterations in the baby oral motor behavior, prolonged pushing, traumatic delivery, forceps or vacuum delivery, intrapartum drugs transferred from mother to infant before delivery. So What can be done to elevate painful nipples due to physical trauma or sore nipples or anything related to that? So examine the breast before and after the feeding. The first step is in a breastfeeding. To diagnose the reason for the trauma. Observe a breastfeeding to evaluate and correct position and attachment. With correct position, pain will often decrease and mother can continue to breastfeed while nipples heal. Check baby's mouth for ankylogogia, clipping of short lingual frenulum, that is frenectomy, by an experienced healthcare giver may be necessary to allow appropriate tongue movements and avoid chronic nipple trauma. Ensure frequent feeding to avoid engorgement. Sharing or changing position of the baby at each feeding may help to avoid friction on the sore area of the nipple. Use of emollients such as purified lanolin may improve rates of healing. Avoid the development of truss scabs on nipple lesions. The use of hydrogel pads may increase comfort for some women with nipple wounds. Breast milk to the nipples after feeding may help some mothers because breast milk contain stem cells. So apply and good nutrition. So sometimes applying the breast milk to the sore breast can also help some mothers. Candida albicans, yeast that causes thrush, thrives in moist environments like the vagina, nipples, areola of breastfeeding mothers and infants' mouth and diaper areas. Infants are exposed to candida during birth and often develop oral and overall growth of yeast is often the result of either mother or baby receiving antibiotics. Infants with recurrent thrush should be tested for HIV. Mother and baby needed to be treated simultaneously, even if symptoms are present in only one of either mother or infant. For mother, nipple and areola candidiasis, nipple may appear red and dry. Areola may be shiny, pink, depigmented, and flaky, or there may be no visible signs. Breast may feel itchy or feel burning throughout and after a feed. Pain may radiate into breast and to the mother's back. So the treatment for the maternal candidiasis: continue to breastfeed, evaluate attachment and make changes if needed. Good hand washing. Ibuprofen can be used for pain. Use disposable or clean dry nursing pads. Wash bras and night clothes in dilute bleach or sun dry. Air dry breasts as much as possible. All pump parts touching milk or breast should be washed and boiled daily. Eliminate alcohol and minimize sugar in the diet. Add acidophilus in the form of yogurt, pills, or acidophilus milk to diet to assist normal colonizing of bacteria flora. And for specific antifungal medication, mycostatin, nystatin through mycostatin has been commonly used for the first-line treatment. This is just only for awareness, and it varies from country to country, place to place, and from situation to situation, depending on the conditions and based on the diagnosis of the medical officer. So increasing resistance and poor absorption of favors other medications, which include monistat, ketoconazole, miconazole, nizoral, fluconazole, diflucan. Although the drug is not approved by US Federal Drug Administration for this purpose, it is sometimes used if other treatments are unsuccessful or if Candida reappears. Gentian violet is a purple dye which, when applied to affected area, works quickly to kill Candida. Even though the baby does not have findings of oral thrush, gentian violet should be used for both the mother nipples and baby mouth. It must be diluted to an aqueous solution of 0.25% for the infant's mouth and 0.5% for the mother's nipples in order to avoid chemical burn of the skin or oral mucosa. If an antifungal medication is prescribed, it is important to complete course of treatment. For baby, oral thrush findings, white cheesy patches on the tongue, palate, buccal, and lingual surfaces, which a mother may think is milk. Yeast is difficult to remove from the mucosal surface without causing bleeding. Milk is easily removed. Baby may be irritable and not feed well. So, for the treatment for oral thrush for baby, continue to breastfeed, wash hands thoroughly. After breastfeeding, apply an antifungal medication to the tongue and all areas of the mouth using a clean cotton swab. Wash, boil, or discard all objects touching infant's mouth, like pacifiers, bottles, and nipples. For the condition babies, Candida diaper rash, the rash may be fiery red, wet, appearing with sharp demarcated edges and satellite lesions. Baby is irritable and fussy and may not feed well and does not respond to usual diaper rash treatments. It is important to examine the infant for the signs of Candida diaper rash and thrush. If the treatment of candidiasis of the mother's nipple and areola is to be successful, the baby's diaper rash and thrush must be simultaneously treated. So, treatment for Candida diaper rash in babies: change diapers often, rinse diaper area with warm water and air dry, apply a local antifungal treatment to the area as directed. If rash persists, the infant, a systematic medication is needed. Good hand washing. We also see a condition of engorgement. The most common cause of engorgement is the infrequent or ineffective milk removal. At the time of milk comes in at 3 to 5 days postpartum, the rapid increase in milk volume can cause vascular congestion and result in edema. This can also happen if the mother or baby skips a feeding. The breast becomes swollen and have a shiny appearance. These may be tender, often feel hot, and have diffuse redness. The mother may be even have a slight elevation of temperature. Intravenous fluids given during labor can result in excessive interstitial fluids and also contribute to the postpartum engorgement and areolar edema. In addition to the discomfort, if milk is not removed, the feedback inhibitor of lactation, FIL, begins to decrease milk production. The treatment is milk removal, and the most sensible strategy is for the baby to attach and feed. Sometimes engorgement and areolar edema may be so severe that the areolar area becomes swollen and hard and nipple flattened. The infant has a difficult time pulling the nipple into his mouth. In this case, or for reducing engorgement, there are certain helpful strategies like a warm shower or warm moist packs to the breast may help the mother relax and enhance milk flow. Gentle massage, hand expression or minimal use of breast pump, hand or electric are often used to soften the areola around the nipple to facilitate attachment. Some lactation specialists recommend using finger pressure to minimize the endomatous areolar swelling around the nipple. This is known as areolar compression or reverse pressure softening. If the baby is unable to latch, judicious use of a thin silicone nipple shield may facilitate latch until the areola is softened. More frequent and effective feedings every 2 to 3 hours or more frequently if the baby is willing. If baby will not nurse, frequent and effective emptying of breast by hand or breast pump until engorgement is resolved. If available, cold packs can be applied after feeding to help relieve congestion and pain. Evaporation from the moist clothes adds to the cooling effect. Anti-inflammatory drugs may be useful. There is not sufficient evidence for other complementary therapies to evaluate their effectiveness. And there may be a condition of an obstructed duct presents as a localized red, firm and tender area in the breast. The obstruction is a result of improper drainage of milk from lactiferous duct. Inspissated, that is thickened milk, can sometimes actually be seen as a white dot or blub on the duct opening on the nipple. The blubs often cause excruciating pain. So what causes a duct to drain improperly? Due to infrequent nursing, ineffective milk removal, usually caused by poor attachment, local consistent pressure on the breast caused by example by tight clothing, rarely but important, an obstructed duct may be caused by a tumor, benign or malignant. So what can be done to relieve the obstruction? Start feeding from the affected breast first. Change the position of the baby at each feeding to encourage more complete emptying of ducts and increase the chance of removing the obstruction. Cease wearing underwire bras and the other constrictive clothing. Empty the affected breast as completely as possible, either by feeding or milk expression. Sometimes warm, moist compresses to area 3 to 5 minutes before feeding is helpful. It may be helpful for the mother to hand express or pump following each feeding until problem is resolved. So infants' fuzzy behavior may cause mothers to think they don't have enough milk, even when they do. Newborns tend to be more fuzzy in the evenings, irrespective of how they are fed. Breastfeeding women tend to interpret infant fuzziness as a hunger, and fuzziness peaks at about 6 weeks of age. The most common cause of low milk supply is ineffective suckling and or infrequent feeding routines that do not adequately stimulate milk production and milk removal. Early introduction before 3 weeks of age of bottles, which require that the baby use a different type of feeding effort or suckling technique, and may cause the baby to have difficulty nursing or refuse to breastfeed. Introduction to formula supplements while calming the infant decreases the number of times the baby breastfeeds, thereby reducing breast stimulation and thus milk supply. Conditions of the baby such as illness or ankylosing may cause ineffective suckling. Ineffective suckling reduces milk supply. Condition of mother such as fatigue, stress, use of certain medications like estrogen-containing oral contraceptives that inhibit milk production, psychological inhibition, pregnancy, and smoking. At around 4 weeks postpartum, normal lactating breasts may no longer become very full before a feed. This change needs mother to believe that they have lost their milk. Mother lacks confidence in their ability to produce enough milk because her baby begins to be fuzzy. Condition of the mother such as fatigue, stress, use of certain medications, estrogen-containing oral contraceptives that inhibit milk production, psychological inhibition, pregnancy, and smoking can also be factors. At around 4 weeks postpartum, normal lactating breasts may no longer become very full before a feed. This change leads to mothers to believe they have lost their milk. Mother lacks confidence in her ability to produce enough milk because her baby begins to be fuzzy or cry more and feed more frequently for several days. This seems to occur several times during first 3 months. Mothers often think they have lost their milk supply because the baby suddenly wants to feed more often, perceived low milk supply. On examination, the infant is judged to be normal. These transient On examination, the infant is judged to be normal. The transient periods of the time when the baby demands to feed more frequently have been called growth or activity spurts. So in case of jaundice, the infant should receive adequate fluid and caloric intake. Effective breastfeeding 8 or more times in 24 hours is the ideal way for the baby to have adequate fluid and caloric intake. If an infant is not suckling well, consider having the mother pump after feeds and give the baby supplements of this express milk, which provides nutrients and hydration. Supplemental water or glucose water does not lower cerebral bilirubin and should not be given. Early follow-up should be arranged, particularly in cases of early discharge. Note that any jaundice on the first day of life is not normal. With rare exceptions, breast milk provides the best nourishment for nearly all infants. The risk-benefit of human milk and the risk-benefit of not receiving milk in a given medical condition must be weighed. In case of structural defects such as cleft lip palate, breastfeeding can be accommodated with an adjustment in the position or can be assisted with a wide Variety. So with this, we shall conclude it here today, and we will see a few more topics tomorrow. Thank you everyone for joining us. We request everyone to quickly fill up the feedback form, which is shared in the form of polls. After the conference, within a week's time, all the participation certificates will be released on the website. You can visit website and download your participation certificates who have registered, attending with minimum attendance and providing feedback. Can download their certificates from the website after 1 week of conference. So see you all tomorrow at 6 o'clock on the 6th day of International Seminar. Take care. Good night. Make sure before you leave, you submit the feedback form, which has been raised in the form of polls. And that is only available in the Zoom platform. Those who have not registered, the registration form has been shared in the chat box. You can register even now and continue to attend.